Thank you for subscribing to the Frequency-Specific Microcurrent podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at frequencyspecific.com/about or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn McMakin.
Yay, we're back.
We're back.
Oh,
I missed you.
I missed you.
Yeah.
I had a very exciting reason for missing work last week, and that was a graduation. So 2 of the 3 are graduated.
That's amazing.
It's amazing when I think about, of course, graduation is such a wonderful time to be proud, but also to reflect on these graduates' journeys. And I couldn't help but just think about my own journey. Of course, it comes back to me because when I think about my start with FSM, especially starting it with the online modules, because I was not in the US at the time and I had babies, and I would have coffee with Carol. And during nap time, that would be my time to sit and have a cup of coffee and just watch videos and watch and rewatch and watch again.
Weren't you in Switzerland?
Was.
And in Switzerland.
Yeah.
And wow.
I know. And
now they're graduated from high school.
2 graduated from high school. Yes.
Wow.
Yeah.
So you've been doing this
2008 was when I saw my first custom care, and I think that's when I started the online education. And then 2009, I want to say, or 2010 was when I went to the Dallas seminar, or no, Austin, Texas.
Oh,
That was my first in-person one.
2008? 9? Had to be. It was before Kevin.
Yep.
We were in, yeah, that's about right. There were bats. I just remember the bats under the bridge and the barbecue at lunchtime.
Yes.
And dinner.
But I do want to talk about that seminar very quickly before we get going, because I know we have a lot to talk about because it's been 2 weeks, 3 weeks.
We are going. You're going. Go.
I came into the course a little bit of a lot as a skeptic. I had seen FSM work with an athlete. I had seen some very important people in our sports medicine community use FSM, speak very favorably of it. So I had some respect for it right off the bat because of who was using it. I felt smush, which I think is backwards for a lot of people, that I had felt smush first and then learned about FSM after.
Oh, okay. Smush is what got you to the seminar?
Smush is what got me there because as a manual therapist, I didn't understand what I was feeling so quickly.
It's as a manual therapist, it's like, this is not possible.
Exactly.
Yeah. No, it's a thing.
It's a thing, but I still had a healthy level of skepticism going into everything. And I don't know if you remember that seminar, but when we had started the initial practicum where we're all holding hands and you're putting current through, and I was the one where I feel like that kid at church that has one eye open to see everybody else had their eyes closed, and I was just like, I'm not sure. I was that part of that bell curve that just wasn't
60%.
sure.
Yeah.
And we had a woman that when you put on 40 on A and 562 on B, she buckled. She was about to faint.
Oh, she was the one we had to put the chair under.
Yes.
That's what seminar that was.
Yes.
And that's when I got to explain, okay, her sympathetic system is what is keeping her upright.
Yes.
And I asked her, are you under a lot of stress? And she said, yeah. And your sympathetics are what are keeping you upright. And I just turned it down off. So sorry.
And to me, I was a believer. That kind of put the nail in the coffin for me. Okay,
Yeah.
Don't fake that. That wasn't a plant. That wasn't placebo. That really happened. And then as the kind of course went through, she was talking a lot about what was happening in her life. And to me, that made perfect sense that if you took down the sympathetics, like you said, that was what was keeping her running, when you have somebody that's redlining like that, and you take away those guide wires, those support systems, they have nothing. They have nothing left.
And yeah, is there more to the story?
No, it's just the validity of coming full circle with the way of thinking.
And that's late last year. That's when we had a practitioner that ran. Now we run 40 and 89 for maybe 30 minutes, at the most 60 in
Yeah.
somebody with a thalamic stroke, or phantom limb pain takes 30 minutes, high leaf, and thalamic strokes takes 60. We had a practitioner with a history of a lot of early childhood trauma, a lot of life trauma. So she ran 40 and 89 for 6 hours. And then that felt so good that she ran 40 and 89 the next day for another 6 hours. And then day 3, she ran 40 and 89 for another 6 hours. And at the end of that 6 hours, she had full body pain. She couldn't think in complete sentences, complete cognitive malfunction, all sorts of dysfunctions. And that was, well, number one, why would you do that? And I emailed her and she said, but it felt so good the first 2 days. I thought, what harm could it do? So I called my neuropsych dopamine geek and said, Patrick, Dr. Wood, what do we do? What happened? And he said, oh, of course, if you completely turn off the thalamus, this is what happens. And then we went from having an hour to having 30 minutes. So he did it as a case report. And this coming March, he's going to do a whole hour on how the midbrain works and what dopamine does in the brain and the spinal cord.
Fantastic.
He's blocking down the calendar. But speaking of, I'm not a skeptic, but who would believe it was possible to completely turn off the thalamus?
Yeah.
I had no idea that you could do that with 40 and 89. I know about reducing central sensitization, thalamic pain, phantom limb pain. I know about all that.
Yeah.
But the concept that we can influence specific brain parts to that degree was,
It's humbling and exciting. And like any time, I think anybody who's been practicing with this modality for any amount of time, when you have those big events, positive or negative, it does bring you back to the validity of what we're doing, to be respectful of it, to proceed with thoughtful reasoning and a thoughtful hypothesis, and to also believe in what you're doing.
and I used that this last week. The patient woke up in the morning. He has sleep apnea, so we're going to fix that. But he woke up at 7 o'clock in the morning with full body right-sided pain that included his head, his face, his teeth, his right leg. He got up, walked around. Within 10, 15 minutes, the right side was gone. And within 20, 30 minutes, his left leg pain started. And so what he had at the end, by the time he got to me, a year and a half or 2 years later, was still just leg pain. And I thought, oh, he had the TIA and it damaged part of the thalamus. So we'll do 40 and 89. Didn't do anything. Okay. So it's not a thalamic stroke. What if, based on what we found out, if you completely turn off the thalamus, what if a portion of the thalamus got completely thrashed? And what we need to do is run necrosis or dead thalamus and then increase secretions in the thalamus. And you know how I feel about that. That was like, and that didn't do anything. After what we've seen with the thalamus, what that told me was it's not the thalamus. So we found mechanical reasons for the pain and treated that, and it was facets. And it's, okay. But it's like you have to understand that without fail, for good or for bad, you can influence the thalamus. 81 and 89 made a guy in a coma cry.
Yeah.
Okay, fine. And then 40 and 89 for 18 hours will turn the thalamus completely off. And then there's no other way to find out what that does. And then they got her back to baseline by finding an FSM practitioner that would look at what happened and run increased secretions in the thalamus, like 10, 15 minutes a day, 3 days a week, until the body pain went away, her brain started working, and the throughput of the thalamus to the cortex and the prefrontal cortex, the throughput came back to normal. And it's okay. Why would anybody believe that's possible until you could actually manipulate the nervous system without fail? That's nuts.
Yes. I have a question. Whenever I don't want to say hesitant, but whenever I think of a frequency and I'm like, I'm not sure if this is where I want to go. For instance, with 81, increasing secretions or increasing the activity of, whenever I'm worried if it's going to be too much, I tend to do 49 first. So vitality. I think of 49 as like the quieter sibling, the shy,
Yes.
introverted. And if that's well tolerated, then I'll try 81, like you said, in smaller segments or smaller bursts. Would 49 have any chance?
No.
You think 81 would have been the way to go with the thalamus in that situation?
Yes. Yeah. And I had a patient come in this week, Monday and Tuesday, because today's Wednesday. And Monday, she showed me her salivary cortisol curve. She wakes up in the morning. What she said was, I don't have any cortisol. And I went, bring your test results tomorrow. And she really, at 7 o'clock in the morning, her cortisol is 0.
Wow.
Then it overshoots, and by 12 or 1 in the afternoon, it's above that blue normal curve. And then it's down in the normal range in the evening. And so Monday, they already had a custom care. So I wrote a protocol for the support the adrenals, which included increased secretions in the adrenals, but it also includes up towards the top, increased secretions in the sympathetics. Because it's like you have to prep the nervous system and tell it, hey, cortisol coming, be ready. So she came in Tuesday and said, oh my God, my brain works. I don't know, I didn't know what it was like to have normal levels of cortisol, but I'm jittery. And I went, okay, let's try take down, instead of 4 minutes or 8 minutes on increased secretions in the sympathetics, I don't want to take it all the way out because you really do have to let them know something's coming. So let's
Right.
just do it for 60 seconds. That's what Roger Billica did. So
Right.
in 13, so we have that data.
Yeah.
And then instead of 15 or 20 minutes on increased secretions in the adrenals, I dropped it back. I think, no, I dropped it back to 12, or maybe I left it at 18 because she felt great. She had even trouble describing this jittery feeling. And I said, that's not cortisol, that's your sympathetics. And so it's like you said, it makes you respectful, and it also requires FSM practitioners to think about what goes with what's the interplay in the neuroendocrine immune system, because she also has MCAS. She also has a bunch of immune system GI stuff. And I said, well, your vagus got turned off. Remind me again how this all started. She said, I got a cat bite and they gave me all these antibiotics, and I think that messed up my gut. But the wheels didn't really come off until they gave me IV iodine contrast, and that just trashed my whole system. And I thought, we have a frequency. So I looked on the buddy, and we have a frequency for iodine. So I ran remove iodine from went in her vein, but I did remove iodine from the veins, remove iodine from the capillaries, remove iodine from the vagus. And then when I got to remove iodine from the small intestine, it was like you gave her some sort of general anesthetic. It's just out. And she said, my tummy feels warm. And then we did remove iodine from the brain and the vagus and the immune system and all the places where iodine kind of doesn't belong. It's a halide, and they're very chemically active. You can dissolve vinyl with betadine, with iodine. Like we used to one night, I remember the graphite gloves. They are graphite impregnated vinyl. So that's plastic, it's vinyl. So I didn't have time to wash them, so I just let them soak in a little iodine bath overnight. I came in the morning and they were gone. They were just goo. I went, halides are very active. This is interesting. Because you think of iodine being in the thyroid.
Yeah.
And just running through what is connected to what? The cortex, the vagus, the adrenals are vascularized, small bowel. It was so cool. And it was a matter of everybody was thinking, she has seen everybody. And everybody was thinking that the antibiotics from the cat bite were the problem. And then after the antibiotics, what did they do? She said, what really made me sick was the IV iodine contrast, because they didn't use gadolinium, they used iodine contrast, because she had a multiple antibiotic resistant urinary tract infection that they thought was coming from the cat bite, but they wanted to make sure that there was nothing wrong with her kidneys. So they did this iodine contrast because it would get the dye into the kidneys and you could see all the capillaries and if there was a tumor there. And so then I ran iodine in the capillaries, iodine in the kidneys, iodine in the kidney tubules. And she left and she was a whole different person. It was amazing.
And I appreciate you taking us through your thought process with this, because somebody who comes in with those symptoms and how they present, you would never think about iodine. You would never think about all those nuggets that actually helped close the case until you pulled out more and more of that history.
And if you listen very carefully, the patient will tell you what's wrong with them. Okay, what happened after the cat bite? Oh, it was the iodine. What iodine? I had this urinary tract infection that was multiple antibiotic resistant, and they tried everything on it. And then she said, iodine, capillaries, arteries, kidneys. It was like,
Following the steps or following the breadcrumbs or following the spark, however you say that. And
yeah,
obviously, this is a very complicated case. You see the more sick, complicated, challenging, think outside the box cases. However, that thinking is imperative to something as simple as tennis elbow, where somebody has exquisite tenderness on the bone and they're going to their doctor and they're saying it hurts here, and they're getting an anti-inflammatory, and then they're getting an injection because eventually the anti-inflammatory doesn't do anything, yet nobody treats the cause of why that tendinopathy is there in the first place. What movements are they doing? What imbalance is there? Is it coming from their neck? There's so many other angles to put at something that is seemingly easy.
and the thing about FSM is, no offense to the people that use lasers, but with a laser, you do, and you have tennis elbow, you do that. You do
Yeah.
the same thing, just in different places. And you might use different wavelengths or different colors or whatever, but you don't need a diagnosis. You're just treating where it hurts. With FSM, we have to figure out what causes it if we're really lucky. And I always hope for this for the new practitioners that took a core last week and they go home. And it's my prayer for you is that easy people walk in for the first 2.5, 3 months.
Yes.
Then you'll be ready.
Yes.
Yeah.
Yeah. And going back to the laser, I do want to say there are so many modalities that can be very helpful with pain. Let's talk about one of my favorite topics is ice versus heat. Everybody knows where I stand on this. And I'm not saying there's never a space for ice. Frozen bag of peas on something that's hot and inflamed feels really good. I'm not saying that ice is not analgesic. I will say that I don't know that ice is really going to help repair the tissue. I'm not sure that frozen bag of peas is going to fix the problem. We are fix-it people. You and I get up in the morning because we love to fix things. And I want to make sure that tennis elbow or whatever it is, that I can get the pain down. Yes, that's great. It's always great to have somebody come in with a 6 out of 10 and they leave a 1. Great. But I want them to wake up tomorrow with a 1 and the next day, and then the day after that is 0. And I never want that pain to come back for that person. And I don't know that a laser can do that quickly. And if it can, then that's great. And this is not a laser podcast. What I'm saying is I've seen those long-term beneficial nuggets happen with FSM that I'm not sure happens with very many other things.
I don't know that anybody else expects it. We have a physical
Maybe.
therapist interviewing to join our practice in the clinic because we have a PT room, and I've been trying to recruit a PT forever. She sells packages, 3 months, 6 months, 9 months. And I went, we might have a little different expectation. And
Yeah.
that is, if they're not 50% better in 3 visits, you're missing something. But can I tell you a frozen pea story?
Yes.
When I was 45, I went mountain climbing in Switzerland with my climbing partner, hiking partner here in Portland. He was a guide for the Iowa Mountaineers. They just finished doing the Matterhorn. And so we're in Zermatt, which is at the foot of the Matterhorn. And we tried for a peak on the other side of the valley. And I got altitude sick. And then we came back down, and in 2 days, we took the train into the French Alps and climbed, I think it was a 15, the dome. And on the way back, we stopped at this little grocery store, and I got 2 small bags of frozen peas. And on the train back from wherever that was in France up to Zermatt, I sat there in the seat with a little frozen bag of peas, one on each knee.
See, there's a benefit to frozen peas. Like, who doesn't love eating them? Who doesn't love like slapping them on knees? They're the right temperature. They mold to your body.
And you can use them on trains.
And you can use them on trains, absolutely. So there's nothing against peas. I'm just saying. There's a difference.
It's a good thing I didn't know about heat, meth versus rice. And just the add-on to that story is a week and a half, 2 weeks later, I had my 45th birthday in a youth hostel in Salzburg, being toasted. They made me stand up on a bench or the table, being toasted with beer at breakfast by a bunch of Australian college students who were on walkabout in Europe.
Wow.
So that's my French Alps, Swiss Alps story.
And I'm sure if we let you, there would be many more stories about that trip, but this is a short podcast, so.
It is. I won't divert us anymore.
You know what? This was actually a very good organic segue to some of the things that are like reoccurring questions that we get, and whether it's at the courses or that we get emailed. So we talk a lot about arthritis, and we talk a lot about you can't put tissue back that's not there. However, again, like the frozen peas, maybe we're not fixing arthritis, but I find that FSM can make arthritis much more manageable. And I think I just don't want people to think, oh, you can't put tissue back that's not there, so you can't treat arthritic patients. I want to make sure that we're chatting about that a little bit.
You know what I tell my patients who are 67 and were bicyclists, rugby players, horseback riders, construction workers, whatever.
Yeah.
And they have arthritic knees, arthritic whatever. Sometimes when you need a hip replacement, you need a hip replacement. Look at the x-rays. Ew, okay. But what I told somebody yesterday was, okay, arthritis in your knees is the price that you pay for not dying at 46 like we used to. The good news is you lived long enough to have arthritis.
Sure.
And so you have a couple of choices. Here's a custom care. I have a protocol on mine, Carol's knee. My left medial meniscus has had a partial tear since 2000 or 2001. So for 24 years. And it bothers me when I do a lot. So I put a magnetic puck under my knee, magnetic puck next to my knee, or both of them next to my knee, and lay on my back, read a book, lay on my back, go to sleep, and run Carol's knee, which is basically the extremity ligament tendon bursa week 1 to week 4, and add 30 minutes on torn and broken in the meniscus, because I wrote those subacute programs before we had a frequency for the meniscus.
Right.
And what's wrong with my knee is the meniscus doesn't work.
Right.
And yeah, so sometimes you have to explain to the patient, this is a management problem, and
Yeah.
this is how we're going to manage it. Ibuprofen and lidocaine, don't take Advil. This is topical. It's not going to bust up your kidneys or your blood vessels or your stomach. And if you can afford it, it's a custom care and a converter so you can treat yourself at night, or just a custom care and you put sticky pads. And oh, Leaf says it was George who put me on Wobenzyme for inflammation. Yes, there are people that use Wobenzyme, and what's the other one? The other enzyme thing. It'll come to me, Leaf. It's in a slide. And once it's in the slide, it doesn't have to stay in my brain, so I don't remember it. But yes, we used to use that.
Moving along to the arthritis, again, you and I are right now are talking about osteoarthritis. Rheumatoid arthritis is a little bit of a different can of worms, which is autoimmune. So we're, again, thinking about the cause. Yes, you get a diagnosis, but like any good FSM practitioner, you're taking the diagnosis, and then I'm also thinking, how did that diagnosis come to be? And so rheumatoid is, like I said, autoimmune. So you're dealing with so many other layers when we start talking about autoimmune, like the vagus.
Infection, stress, trauma, leaky gut, because the things that they put you on for rheumatoid arthritis trash your small intestine, which further disrupts vagal function.
Yeah.
And then what's fun, I think it's fun, is that you can still treat them even if they are on Enbrel or any immune suppressant. That's pretty interesting.
Yeah.
And yeah, rheumatoid arthritis, I thought it was redundant to put those two parts of one slide. There's degenerative arthritis, which is inflammation, necrosis, torn and broken in various joint parts. And then rheumatoid arthritis, treating the joint is the least of your worries.
Yeah.
Is that a different dog?
No, that's the gray dog. He
looks brown.
He looks brown on the, I don't know why. Maybe it's just the lighting back there. It's
okay.
Same
Sorry.
old gray dog.
He's my favorite.
He just
Don't tell the other dogs.
yeah. The shepherd might have an opinion about that.
Yes.
And then the last thing would be that I want to touch on that I think about with the joints and the questions besides the arthritis is osteoporosis. Yes, insert eye roll. So those of you who are listening, that was what just happened there. So osteoporosis, again, doesn't have to be so complicated. We're not curing it. Again, it's a management issue, and I've been very successful at help managing the symptoms. It's nothing to run away from.
And you find out what the vitamin D levels are. And it really depends on who saw them, what their GP does. Some of the medications they use for osteopenia or osteoporosis make the bone look better on x-rays, but the data says that it doesn't change the fracture rate. So osteoporosis is, if it's not from the use of steroids, if it's not from gluten sensitivity, the best description I ever heard of it was a long latency vitamin D deficiency. So if your vitamin D was 12 during your childhood or young adulthood, and now you're 52 and you are gluten sensitive, but let's say you're 52 and you have been on proton pump inhibitors for 10 years.
Right.
You can't absorb calcium or pretty much any mineral, and your vitamin D levels are still under at 20 or below, so they never did hit 30.
Right.
And so you can relieve the pain. You treat it as if it's a fracture. You look on that little chart that we have in the core, and I'll put them on 5,000 units or 10,000 units a day for 30 to 60 days and then redo their levels plus K2 until their levels are between 60 and 80. And then you use the same supplements like bone strength from New Chapter, use the same supplements that you would use for a fracture. And so you can relieve the pain with FSM, but how do you turn around or slow down the process? And didn't we have a case report from somebody that increased bone density?
Yes. That sounds very
Familiar.
Yes, it does.
Okay.
Yeah, like nothing to be afraid of, or to just because you can't cure it doesn't mean you can't help manage it. And that can be, and that could be a bit of, I'll take some responsibility because I talk a lot about fixing things and closing the door and but then there are those cases that you just have to look at it logically and think you are not going to remove this pathology, but you can help manage it. And that itself is great.
This is a management problem. And
I
they
love
look at you like, huh? That's how you changed lube oil and filter in your car.
Yeah.
It's a management problem. Oh, okay.
Yes.
Then it's less scary.
It is less scary. And even with those cases that are so overwhelming, the ones that you see where as you're talking about it, my brain starts like spitballing all these angles to go to, and you get to the big part before I would even think about going there. But I do trust I eventually would have gotten there. You get there a lot faster than I do. I take the scenic route sometimes.
Oh, the scenic route.
Right. And I think as long as we're, like you said, making a change in pain with those patients, you give it 3 visits. I will also say to new patients, give me 3, and we'll know very quickly if we're a good fit within, I would say, the first visit, but let's commit to 3. And it is so exciting to see that little bit of disbelief. Like we talked about skepticism when we first started talking today, there is some skepticism that comes in with patients, and I welcome skepticism. Let me prove you wrong. I welcome the challenge, and I think you should never just walk into an appointment and think this is going to be great, or I'll give you, like, I think we should always ask questions to healthcare practitioners.
It's almost easier to deal with a patient who is a little bit skeptical.
Yeah.
At least for me, than it is to deal with a patient who saw us on YouTube, who listened to the podcast, who read the book, and expects it to get fixed in 1 or 2 visits with no effort on their part. It's, oh, dude, let's have a conversation about that. That's
Right.
not how it works.
No. And it is funny to get those referrals of you fixed my friend in 1 treatment. I believe that you can fix me in 1 also. And the pathology completely different and different people, right? Like you and I talk a lot about pattern recognition. And while that is helpful, you have to still have that flexibility to say, okay, this traditionally will work in this sequence. However, I respect the fact that this person is an entirely different cellular makeup and I might have to pivot. And that to me is what is exciting. That to me is how I feel like I'm learning every day with every treatment.
That's why the other reason we spend so much time on the stable state. The other advantage that I had, once again, talking to this physical therapist who also has a degree in what she calls functional nutrition, functional medicine, but her training is an entirely different lineage than I had with Jeff Bland. She doesn't know the biochemistry, she knows the supplements. But listening to Jeff starting in 1995, it was the chapter 2 of Goodman and Gilman. And listening to him was learning to think in terms of this is connected to that, but in order to do that, you have to do this over here. And when you do this over here, in order to get this to work, you have to do that to the small intestine. And he never included what we have as our magic weapon, which is treating the vagus. If you can turn the vagus on, everything gets easier
Yeah.
in leaky gut. And it's just all that.
We'll say it probably 100 times in one podcast. It's learning to think. And the minute, and to me, that's the exciting part of not only working with it, but teaching other people how to use it is, no, it's not a machine that you just slap on somebody and leave the room. And if you want to do that with the TENS or do that with the laser or do that with something else, but not with this. And if that doesn't fit your practice or your practice style, then so be it. But to me, I couldn't imagine, wholeheartedly could not imagine practicing without it. For fear of what it would do to my critical thinking skills.
Yeah, exactly. And the most distressing thing I ever hear from patients are that they saw an FSM practitioner who put either wet towels or sticky pads on them, punched a button, and left the room.
Yeah.
And then sent their assistant back in to unhook them and have them come back the next day.
And we'll say it again for the people in the back, like that is never how this is taught. From me, from you. And yes, there are recovery protocols that I absolutely teach, but I teach it in the platform of after you have seen them. And in order to support what you have done in the clinic, send them home with it. Let's make a clear separation of unassisted versus like what we're talking about. We do have a couple questions. So I'm going to scroll back up here. In a seemingly healthy person under a bit of work stress, what would cause nervous tics in hand and arms? Is there a frequency or custom care program to help with that? Maybe concussion in Vegas, question mark. And then not in the hand and arms, but a nervous tic in the nose. So sniffing when stressed.
Wait, okay. How do you have a nervous tic in your nose when stressed?
So sniffing.
And then what happens to your nose? If I sniff, then how does it?
Interesting. Maybe they can extrapolate a little bit, but
Yeah.
we get nervous tics a lot when stressed, like people's eye can twitch and
Meg, it's when you get under stress, a couple of things happen. It's
the nervous tic is sniffing.
yeah, is sniffing a lot. That's interesting. The only thing I can think of is the vagus is turned down by infection, stress, and trauma. And the vagus has as its job to suppress the immune system. So if the immune system gets more active and starts mucking about your sinuses, then maybe there is something to sniff about. And so that's the only connection I can think of. And yeah, there's that.
I think with anything to help somebody with stress, and so we're talking about work stress. So I would talk a lot about the work stress and like, what about the work stress is stressful? Is it a deadline? Is it a coworker? Is it keeping you up at night? Is it messing with your digestion? Like I would ripple out that way. The sleep is always going to be the biggest thing that I want to assist with. So if great, there's a tic, great, there's a sniffing. But if we can help with sleep, so right away I start thinking of how can we support them in the clinic? What can I give them on the custom care to take home to maybe help them sleep? Like there's anything I've learned from all the wonderful functional medicine doctors that we have had at our meetings is sleep. If you are not sleeping, nothing else matters.
That is like David Musnick's mantra.
Yes, and Jennifer Sosnowski and Roger Bilga. But let's get these people to sleep.
Well, and do you snore? And what's your blood pressure, pulse? If you're on 2 or 3 blood pressure medications and you snore, you have sleep apnea.
Right.
So we're not doing anything until you have a sleep study. Oh, I don't want that thing. So we have this whole conversation about dying when you have sleep apnea. That's a thing.
Yeah.
So that's the only thing I can think of that would, Lisa, you got it right. That would be where I would start. Concussion in Vegas, quiet I'd also do a urine mold test. It's like mold and colonizes the sinuses. So
The person has a runny nose, or if it's just a sniff, are you just doing that, but there's actually not anything with the mucous membranes?
fair enough. Yeah.
This is
So
interesting.
it'd be a good question to ask, though.
So
You
this is
sniffing something, or are you just sniffing as a nervous habit?
And again, I'm going back to the work stress. When we think about people who are redlining, again, this podcast is wonderful for going right back to the beginning today. It's very
Congruent.
difficult today, yes. So we talk about people who are redlining, who have so much stuff, and what they're telling us. I have a lot of work stuff. Like, who knows what's underneath that glacier that we're just seeing like the top of. We all know from our own experiences, like when we have a lot of stuff that piles up, maybe she's saying it's work stuff, but that's the outlet. Like maybe there's other family stuff, maybe there is chronic pain, maybe there's all these other pieces, and what's coming out is, or what they're recognizing, what they're putting together is, I have stress at work. So
And then there's the question you ask on their first visit. And this is the only question I ask on the first visit, where I have husband, whoever came in with them, can you
yeah,
step outside for a minute? And you have them step outside. And so you've already asked the patient, how many surgeries have you had? What trauma have you had? And then the question that you have, it's just you and them in the room. Have you ever been molested, raped, or abused? And kidnapped, surgery, auto accidents, stress before the age of 7. And honest to goodness, the number of times where I'm the only physician who's ever asked them that, because there's work stress and then there's central sensitization, where what would be perceived as normal, just mildly aggravating to a coworker who had not early childhood stress, who hadn't been molested, raped, or abused. That's just they just float right over it. It's like a duck on the water.
right.
A person who's been subjected to early childhood stress, molested, raped, abused, or just raised in a violent family, that person, the stress at work affects them completely differently neurologically, endocrinologically. Their midbrain jacks up sooner, their vagus turns off sooner, their sympathetics jack up sooner, their epinephrine and norepinephrine go up sooner. That just,
Yeah.
and yeah, so.
Yeah. There's one more little nugget that came from this sniffing. Hang on here. I just saw it. More clues. Where did it go?
Direction, I thought of more clues and have a direction, scarring, and the turbinate since, okay, sorry, I'm having trouble finishing this sentence. Since he had them removed many years ago, we didn't look at that because we didn't have a way to address it. Yeah. Then we ask, I can't fix that they took your turbinates out. Can I ask you why they thought that would be totally gross, Lisa? Sanded down? That must be a little Canadian A at the end. No, deviated. Okay.
So there's stuff.
Yeah, but the septum and the turbinates are different. The septum's up here, the turbinates are down here.
Yeah.
But still, that's where the history comes in. Have you ever had surgery? And
Yeah.
then problems in my nose. Have you ever had a broken nose? No, but I had a deviated septum, so they took out my turbinates.
Right.
Okay.
So there's that.
That's okay. And then
Couple more questions. Oh, yes.
I got a Dana, this
Yes.
one. PPIs inhibit calcium absorption. Duh. That's a 24/7 situation. Yes. Can they take calcium, say, first thing in the morning before the PPIs? Maybe.
And for the lay people listening, PPIs are proton pump inhibitors.
Right. And everybody should know that proton pump inhibitors and things, easy things like Tagamet and all the over-the-counter stuff, they've never been studied for use longer than 2 weeks. All of their FDA approval is based on studies for use, safe and effective, if used and for 2 weeks.
Wow.
I saw somebody yesterday that's been on Protonix, which is a prescription strength proton pump inhibitor, for 19 years. And she has osteopenia.
Right.
Okay. You're going to do this first. And one is, right, she said, I'm on proton pump inhibitors because I aspirate. I said, do you aspirate? Not exactly. I cough all the time. Okay, that's the acid, and that's in your trachea, because that's what makes you cough. And I found that out treating my cousin, because I got rid of the cough by treating inflammation in the trachea. And so they just bought a new mattress with a box spring, so they can't get an electric raise the head of the bed platform. So you get bed risers and you raise the head of your bed by 3 to 6 inches. Start at 3, see how you do. And then we treat the vagus. And then you don't eat anything after 6 o'clock at night. And then there's that whole list of things you don't eat at all. And then there's that one slide, how to get patients off proton pump inhibitors. And I said, that's the last thing we're going to do, because that will take 6 to 12 months. Protonics for Tagamet, 6 to 8 weeks, maybe 12 weeks. It's yeah.
Dana added patient has
It's
esophagus.
scarred, scared to go against the gut, of course, despite the evidence that PPIs do so much harm and possibly cause the Barrett's. And Barrett's esophagitis is a precancerous. It's so much inflammation in the esophagus that I can't remember what percentage of it turns into cancer, but it's considered precancerous. So it's inflammatory. So we have a frequency for the esophagus, 26. We have a frequency for reducing inflammation, for ulceration, which doesn't do that much. We have a frequency for reducing acid, but an awful lot of what we interpret as esophagitis or reflux is eosinophilic esophagitis. So which is you're eating a bunch of food you're allergic to, and eosinophils are the white blood cells that deal with allergies.
Right.
And this allergic food goes down to your esophagus, ends up in your stomach. The eosinophils just climb right past that lower esophageal sphincter and go up the esophagus.
Right.
And create a bunch of inflammation. And after a couple of years of this, so the other thing you do with somebody with that kind of esophagitis is you put them on. I am assured that there is now an IgG food sensitivity test that is useful. That being said, you just take them off of wheat, corn, eggs, soy, milk, citrus. 6, right? Yeah. And I'm not even nice when it comes to that. It's give me 6 weeks. Friday of week 6, you can have all of them in one day. Why on Friday? If I'm right, then you're going to feel so awful on Saturday or Sunday that we won't ever have to have this conversation again. Okay.
One last question, and we are already over by 3 minutes, but a good frequency for Hep C. Is that a
Oh my. Okay. Hep C is a virus, right? It's a virus. Okay. And we have the 1 or 2 Rick Coy case reports. So you run, Kevin, you erased already.
Sorry, that was me.
Oh, okay. You run he used malignant virus and he used liver support, liver virus, liver fibrosis, and the patient's viral count was 0 in 6 weeks. And that's just running 160. We've got a lot more virus frequencies than that. So you could build something for Hep C. The other thing is with hepatitis C, they're using interferon for hepatitis C, right? That's the one they use. And the trouble with interferon is it makes you really sick, and it's $10,000 a month. And then everybody's heard the story about how I heard in immunology, pre-med, how because the teacher said vitamin C increases interferon. How does it increase interferon? He said, I don't know, but they know it does. So when I wanted to exempt a paper in chiropractic college, I decided to do a paper on that. So that was back when we had 411 directory assistants. So I called Linus Pauling's house, right? And his wife said, he's not here, but you want to talk to Irving Stone. So she gave me the phone number. I called Irving Stone. His wife answered. He's at a conference, but he has a postdoc that just presented a paper on this very topic. You should call him. Here's his phone number. So I called this guy and he got so excited. He said, vitamin C, the white blood cells pump vitamin C into specifically white blood cells using ATP driven pumps. They actually use energy to pump vitamin C into white blood cells. They line it up on the inside of the cell and they use it, or maybe it's the inside of the mitochondria, but probably the inside of the cell. And it increases the voltage drop because if this is positive and this stays the same degree of negative, it falls further. Does that make sense?
Yeah.
This is more positive. It falls. It's like Niagara Falls versus a little waterfall.
Yeah.
So it doesn't just increase interferon, it increases all immune system fractions, and it increases the mobility of the white blood cells. So you get more interferon, and then the white blood cells travel around more easily because they have all this extra ATP. And then they package up the extra vitamin C into little bombs, Golgi packets, and they get over the virus and they drop the vitamin C onto the virus. And the vitamin C is acidic, so it basically burns a hole in the outer cell of the virus and kills the sucker. So that I would do. And Rick Coy, he called it liver 1, liver 2, liver 3, liver support, liver virus, liver fibrosis. And at the end of, it was something crazy like 6 or 8 weeks or 12 weeks, the patient's viral count was 0.
Amazing.
We have an N of 1. So that isn't prove anything, but it's suggestions can't hurt, might help.
Yeah.
Is that really 7 minutes after?
It's 8 minutes after, but that's okay. We had some bonus time today.
We did, to make up for the 2 weeks we weren't together.
Yes. We're back next week, I hope.
Yes.
Good.
Yay.
We'll talk to you then. Thanks everybody for coming, and we'll see everybody same time, same place next week.
See you next week.
Bye.
Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.